Hello, everyone. I am Dorina Esendagli, and I work as a consultant pulmonologist at Başkent University in Ankara, Turkey. I'm here as the ERS, Early Career Member Representative, and I'm so glad to be with the guest editors of the monograph COPD in the 21st Century. So we have here Peter Calverley, Emeritus Professor of Respiratory Medicine at the University of Liverpool in UK, and he continues to work in the Institute of Life Courses and Medical Science. His research interest focuses mainly on the pathophysiological and the management of COPD. He was a founder member of the Global Initiative for Chronic Obstructive Lung Diseases, GOLD, and chaired its Dissemination Committee and Scientific Committee. We also have here James Allinson, who is a consultant respiratory physician at the Royal Brompton Hospital in London, and he is also an honorary senior clinical lecturer at the National Heart and Lung Institute. He leads research exploring how COPD and lung health develop across the life course, aiming to find ways to improve the treatment of those with established disease. So welcome to both of you.
Thank you very much.
Thank you.
So I will start with my first question. How could you define COPD in the 21st century? What is new regarding the definition and the understanding of the disease in the new millennium? Peter, maybe you can address it.
One of the big struggles historically has been to define it in a way that worked operationally. And that happened effectively really as late as the 1990s and certainly the beginning of this millennium, when the Gold Group came up with a functional definition based on the presence of characteristic symptoms, breathlessness, cough, sputum production, together with known risk factors which were likely to lead to COPD and the presence of objectively defined airflow obstruction. That definition has changed, as is outlined in one of the early chapters of the monograph, changed some 5 times, but always has focused on the presence of airflow obstruction, usually defined in terms of its persistence and presence on each occasion. The major changes that are now happening that might lead to further modification of that definition are, as usual, technologically driven. And these are also described in different chapters of the monograph, which James and Peter M.A, who unfortunately couldn't be with us this afternoon, and myself produced. There's been a big focus on trying to identify COPD earlier in the natural history and perhaps incorporate features that suggest structural lung damage in the definition. The definition's discussed in a couple of sections in the monograph, particularly David Halpin's really very thoughtful chapter about the definition. But James handled that and perhaps should have a chance to get a word in edgeways.
I'll try and match your wise words, Peter, but I'd echo what Peter says in that the original definition was practical, operative, but also pragmatic. Because at the end of the day, we need a definition that we can apply widely, and that's so that we can recognize disease well and treat it on a large scale. But that pragmatic definition has its weaknesses, and we increasingly find this as technology has moved forward. And so we'll all be aware of the people who don't quite fit into those existing definitions. So people who have COPD-like disease and almost meet the criteria, but don't quite. We have the new entity of PRISM. And then we have this very attractive and historically appealing group of people who are going towards COPD, developing it, and perhaps can be viewed as an early stage of COPD. So those are the challenges, but I think we've got to really value the heritage that comes with the existing definition of COPD. It's been well established. We know that the drugs work in those people who meet those criteria. And although it's not always well applied, and people don't always do spirometry when they should do, actually, it is deliverable on a global scale, that diagnosis. Handheld spirometers are available. And so we've got to be a little bit cautious when moving towards new and exciting definitions, that we don't lose the benefit that the existing definition can be derived from that can be given to the wider population. Does that make sense to you, Peter?
Yes, I think that's a fair summary. I mean, the countervailing point of view about the value of changing the definition, there's a helpful table looking at this in David Menino's co-authored chapter on epidemiology of COPD, which does emphasize that COPD still is a big global problem, but also suggests ways in which we can produce a more nuanced definition. I think when you read that table critically, you recognize the points that you laid out, that it's very good to have a definition which is intellectually robust and which maybe addresses the fact that COPD is a continuum. It's a disease that begins before airflow obstruction occurs, but becomes definable once that stage has been reached. And there is an urge to go earlier into COPD, but operationalizing some of these other definitions is a real challenge at the moment. That's not to say it won't happen, but that's something to look forward to in the future rather than something that's here and now.
Although I was a little bit advocating caution in just rolling out new definitions too quickly, I think there's a great need for research, as illustrated by a whole number of those chapters, into how we can better recognize the aspects of disease that we currently potentially miss and then reach those patients appropriately. So, a great unmet need of research, I think.
Yes, and I agree that the definition is very important in order to standardize the approach and also the way of treatment of this patient globally, not only to a specific group. But despite the research and the progress that is being done in the field, COPD remains still one of the most common diseases with a high morbidity and high mortality worldwide. So, Peter, what are we missing? What do you think? What is the problem here?
I think that there is certainly abundant evidence that the mortality and morbidity from COPD globally is very substantial. Indeed, it's a classic example of the more we look for something, the more we find it. And for a long time, people never looked or thought about COPD. And for the last 30 years, that's changed. A paper that was published just after the deadline for our monograph, which is the current version of the Global Burden of Disease study, was actually published in May this year, shows very clearly that COPD will continue to be the third commonest cause of death worldwide. And one of the striking projections, and this group have a good track record with their projections, is that in terms of disability-adjusted life years, COPD will move from being sixth in the commonest non-communicable diseases at the moment up to fourth. So in terms of its impact globally, it is going to be something that will persist. I think to answer your questions to what could we do about it and why has it changed, well, we have identified some very key important factors. The obvious issue is tobacco smoking. And in Western European and North American communities, that's in decline. That's not the case in other low and middle income countries, and indeed in rising income countries like China. But we've also recognized that COPD can arise without tobacco exposure from other factors, particularly early life factors. And in global numbers terms, these can be very important factors. So we're recognizing that there's many routes to developing COPD. Again, that's nicely summarized in the chapter on natural history and trajectories of COPD that considers how gene and environments and time interact to lead to this increased number. So we've got to be aware of that and take a wider view of COPD than just saying, oh, it's down to smoking and this is what happens if you're a heavy smoker.
I completely agree. And some of the factors Peter mentioned, they're almost encapsulated often within the umbrella of poverty and deprivation. So poverty and deprivation across the whole life course has set people up to develop disease or worsening disease, which we then diagnose much later in life. So some of those interventions, tobacco abstinence and prevention of people taking it up is very much key to COPD. But there are other things that we should be doing to protect lung health, such as preventing poverty, improving household living and reducing pollution exposures across the whole life course. And those are very difficult interventions often to make. Another factor that has really been an uphill struggle is the stigma that patients with COPD often feel. And the first chapter in the monograph, I think, is a really excellent chapter that I've already cited, in that it reports in the voices of patients how they feel about COPD, how they feel about their care and what their needs are. And they do report this stigma, which has contributed perhaps to the disease not achieving as high a status as it should have done, given its mortality, and perhaps not attracting the attention it should do in terms of research into preventing it.
Yes, that chapter is really quite impressive. And I think that we should listen to our patients in order to improve our clinical approach. But maybe there are a lot of causes that are causing COPD, and we still stay at the end that we have this only disease called COPD. So it is early life stage also that is influencing the development of the disease, as you already mentioned. So it is quite crucial then to early diagnose and to prevent this at the early stages. What do you think? I mean, what can we do for the early diagnosis of the disease? And will it prevent later on the development or the progression of the disease to a more severe stage? What do you think? Peter?
I think that it's a sort of holy grail idea that we should be able to diagnose this disease earlier and we should be able to take action. I think if the best things I can say at the moment is think about the possibility that COPD might be a consequence of an exposure, of a failure of the healthcare system. If you think about it, and we now do have a much better model of the natural histories of COPD. It's not one disease beginning at age 40 and progressing to age 70. It actually reflects a whole lot of early life course events. And many of those are much more tractable than COPD that we think about in the clinic when we've already seen the results of years of damage. So better obstetric care, better nutrition in childhood, avoiding smoking in mothers, avoiding other factors that lead to reduced intrauterine growth, better nutrition during the years when lungs are growing, reducing environmental exposures that are harmful for lung health development. COPD is one of the great marker diseases of what happens if you don't do this. And in a way, that's why I said previously, we've got to broaden this out just from beyond thinking about tobacco. Obviously, there are other factors that come along later in life. There is a whole group of COPD people who develop persistent airflow limitation and the features which are very like COPD, in fact, indistinguishable because they've had chronic asthma. And they only get a diagnosis of chronic asthma because you knew in the past that they had reversible airflow obstruction. Sometimes people with exposures to acute toxic exposures, I suppose the best studied group have been the 9/11 firefighters, where you get a reactive airways disease syndrome, which eventually begins to progress to COPD. So there are lots of different pathways, each of which offers an avenue for intervention. And then there's a concept of trying to diagnose a disease objectively sooner, which is really relies on understanding perhaps how to apply physiological tests like spirometry, but perhaps some of the other subtler ones, and perhaps a greater use of pulmonary imaging. But they're still, as far as I can see, at the research stage, and I'm not sure we can make the case yet to devote mass spending of healthcare systems on those interventions. What we need to do, and is being done, is collect the data to see if it is worthwhile. You can certainly identify abnormalities in people who are smokers and have normal lung function. And that's something that's quite near and dear to James and my heart.
Absolutely. And all those markers, Peter, that we're picking up of being perhaps the origins of these different pathways to COPD, they should be perhaps seen as warning signals on a dashboard in the future that should lead us to look a little bit more closely at those patients. And whether that's doing their spirometry early in life or something else in early adulthood, I don't think we know that yet. But that is, potentially something we should be doing in the future. And even if they don't go on to develop COPD, actually improving someone's childhood or adolescent or early adulthood respiratory health cannot be a bad thing for their later respiratory health. So then this could be seen as a whole. What can we learn from COPD with regards to actually improving lung health for the general population? And as Peter said, that's slightly we can do some of that now, but actually there's a big thing out there where we haven't diagnosed the people perhaps who we should be diagnosing who already have COPD. And I think there was a recent New England study, I don't think we made it into the monograph, where they automatically phoned up about 1 million people, and they eventually managed to get, I think, 500,000 into screening and then actually diagnosed them and treated them. And those people obtained benefit from that diagnosis and treatment. So I think there's two focuses really, as Peter's outlined. There's the recognising the established COPD that we haven't yet diagnosed, the missing cases, but also recognising that people are on a pathway towards poor lung health.
Yes, thank you very much. Another challenge that we face as clinicians is that after having diagnosed a COPD patient, not everyone is progressing the same. So we have similar spirometry results, but we see that some patients are doing great and are living for a longer period, whereas others are having exacerbations, hospitalization, and mortality is higher. So there is a problem also with the heterogeneity that we have, and also for many comorbidities that these patients as well. So how should we tailor the treatment? What does the monograph bring as new for the treatment of these patients?
I think the monograph provides a lot of really important knowledge, which will help people decide on how to treat. For instance, of the areas that you highlighted, it's clear that COPD is very often, once established, once you've got beyond about gold grade 2, then COPD is very often a multimorbid condition. And those multimorbidities combine with COPD to enhance the burden on any individual patient. So getting people to think again beyond the silo of it's just COPD, I've got to follow this sort of decision tree, but to recognize that other factors are just more likely to occur. Cardiac disease in particular is an issue, and there's a nice chapter from the group in Birmingham, Alabama, Mark Dransfield's group, which actually summarizes the evidence there and the interactions, which are now getting pretty well established, between COPD not just as being present coincidentally, but as also contributing to cardiac problems, especially during acute exacerbations. The monograph outlines as well the thinking behind current guideline approaches, and particularly tries to highlight the value of a treatable traits approach, where you look at people and you say, yes, this is somebody with COPD, but their COPD at this stage, the biggest problem is breathlessness, or the biggest problem for the patient is exacerbations. So let's make sure that my treatment approaches, both pharmacological and non-pharmacological, are there to address those problems, to ensure that it isn't just a one-size-fits-all. I think that's one of the big themes now in COPD, to identify different phenotypes, perhaps different endotypes of disease, and to consider what's the most appropriate treatment for somebody with that set of clinical features.
And James?
As well as the heterogeneity, in just as a cross-section, we've got to perhaps think of COPD, we're in it for the long haul with the patient. So this isn't about a one-stop shop and then it's all done. Over time, things can change. So cardiac mobility can get worse, obviously, but some things can improve and change. So the exacerbation frequency, it may decrease, and there is opportunity to decrease it and change that course. And the kind of the phenotype of a patient has to be potentially revisited over time serially, and that's something we need to think about. So it's not just a one-off phenotyping for COPD patients, they're often more complicated than that. And as you said, you mentioned the group that do badly and are doing worse, and that should really provoke clinicians to think, why is it? And what are the potential targets that we're missing, and how do we reevaluate that in the future for that patient?
And I think the monograph tries to pick up on some of the practical aspects of that. It's a rich source of information about, if you will, how we've transitioned from the one approach to the other, from the traditional approach that looked at pharmacotherapy as everybody in a clinical trial is going to receive this bronchodilator or that bronchodilator or this inhaled steroid combination, to something that is more targeted. And there's chapters reviewing the approaches to that. And I think considering the role of applicable biomarkers, blood eosinophil count's the one which is most popular at the moment. And there's a good chapter by David Singh and colleagues which gives a very up-to-date overview of why we think eosinophils might be important, and the evidence that suggests that we should be offering different therapies according to what the blood eosinophil threshold is. That's certainly been a big driver for new therapies. And the group from Leicester in the UK have written a very comprehensive overview of the many different treatment approaches that are in development and will be applied in the next 10 years, often linked to specific phenotypic and endotypic features of disease. So I think we're getting a more sophisticated appreciation that people will need different therapies according to the way their illness is affecting them at that time in its natural history.
This overview actually is also stressing that we have to go for a personalized treatment for each patient, maybe by taking into consideration all the risk factors, the reasons, the causes, the etiology, and also the heterogeneity of the disease together with comorbidities and other treatable traits, as you said. So what do you think are we going to address in the future, maybe for the next monograph? What do you think will be the topics that we are going to deal with?
Oh, future. You want a quick answer on the horizon scanning? Well, we tried to give a chapter at the end of COPD at a tipping point, which tried to look at some of those options. I think there will be new knowledge. Our treatments and our management approaches are always altered by new knowledge. New knowledge can be accumulated in physical therapies. We are getting better at refining the people who benefit from medically based surgical interventions like lung volume reduction. But I think the major new knowledge is going to change how we view COPD and what drives its progression. I think information about the microbiome, potentially still about genetics, although I'm not as optimistic as some people about the impact of genetics in COPD. But certainly the microbiome, perhaps about mucin and its role, particularly earlier in disease, as we have these cohorts that develop. There's one in the UK called Beacon, there's another in the US called Source, which will give us understanding about how COPD evolves early on in the disease when there's a chance we can intervene really effectively. But James, again, as a younger man, you get the chance to really speculate.
Gosh, are we talking about COPD in the 22nd century? Is that what we're speculating up to?
Oh, you're pessimistic. You're being the late 21st.
Okay. Well, it's interesting because when you go back and read the historical literature, the themes that we are dealing with today in this podcast, actually, they have their roots back in that historical literature. So we haven't completely reinvented the wheel with COPD. We've merely built on the foundations of our predecessors. So I suspect we will probably still be talking about themes of how we can even better treat people and how we tailor treatment to their phenotype. But the technologies that are emerging, I'm always astounded by how quickly technology moves, may well take that to higher and higher levels, which would be brilliant. And it's just always a challenge, isn't it, to grapple with these new modalities and assimilate all the information in a way that we can interpret to the benefit of patients. So that's definitely a challenge. One thing I think we picked up in the last chapter was actually how COPD may have changed and may be changing, particularly in some areas of the world. So as societal conditions change, as our exposures change, and Peter's mentioned the drop in smoking, for example, in some high-income countries, the manifestation of disease and chronic respiratory disease, what we know as COPD, may change in its character. So that is going to be really fascinating to watch. Will probably give us indirectly some information about what the disease is and what drives it and how the mechanisms underlying it. So that may well be a topic for future monographs.
Well, it seems to me as a clinician that these things will be much more complex and it will be so difficult to treat these patients, but it is worth it. Will have a better outcome at the end. So you have done a great job with this monograph. Just I want a take-home message for the listeners from both of you, if possible.
COPD is evolving, but we can manage it better and we should manage it better.
And Dr. Allinson?
I think if you look at the thickness of the monograph, it is a really heavy tome because there is so much work going on with COPD. I think it's a really exciting field to work in, both in terms of the academic research side and to be managing patients, because we're increasingly be able to benefit patients more and more. So it's a really fascinating time to be working in COPD academically, and it's a fantastic time to be working with patients who have COPD.
Thank you very much to both of you. It was a very comprehensive and very informative talk. And thank you very much to the listeners that have been here with us. I suggest and recommend that they read the monograph from the beginning till the end, because they will get even more detailed information on very updated topics about COPD. So thank you very much and goodbye.